Welcome, friends. It is our great pleasure to introduce you to SICOT Pioneer. Pioneer is a program of innovative orthopedic networking, e-learning, education, and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Right, a very good morning, good afternoon, and good evening, ladies and gentlemen. I'm Vikas Khanduja, consultant orthopedic surgeon in Cambridge, UK, and one of the founders of SICOT Pioneer. And it is indeed a pleasure to welcome all of you logging into this webinar from all around the world. Now, in the COVID world of non-contact domains, we certainly embraced digital competitiveness with the launch of SICOT Pioneer. And through this platform, we've done over 45 events and have now had over 70,000 views from 110 countries around the world. So a big thank you for following us and joining in as well. Now, today's webinar is focused on the subacromial balloon spacer. And after today's webinar, it may never be heard of, we'll see. And it's been carefully designed in collaboration with SLAHOC and SICOT. We are ever so grateful to Professor Inho and Professor Gudio and the stellar faculty who've given up their time for this webinar, and I'll let Professor Inho introduce them to you in a minute. We'll try and make this webinar as interactive as possible, so please do post in your questions, and if you can't join us today, then you can access our on-demand platform as well for this webinar later on. Once again, a big thank you for joining us, and hope you do enjoy the webinar, and I'll hand over to Professor Inho and Professor Gudio for the proceedings. Thank you.
Thank you, Vikas. Thank you very much for your kind introduction. Hi there, I'm Professor Inho Jan, Chair of SICOT Shoulder Elbow Committee. Thank you very much for your joining this special webinar. As Vikas just mentioned, this webinar is very special because the SICOT Latin American Shoulder Elbow Society and Colombian Shoulder Elbow Society are working together to create a new idea on subacromial balloon procedure. And I'm so happy to have three experts on this field, particularly Dr. Steve and Andrew and Nikhil and Guido. So without further delay, I'd like to give a short introduction why this has been so much important for us all. So we all know that rotator cuff surgery has all different phases. And as you all agree, massive rotator cuff tear is a challenging issue for all our shoulder surgeons. So how to deal with this massive rotator cuff tear? Our experts hopefully will give you a better idea and new insight on a new treatment. I believe this balloon procedure, due to this balloon procedure, we are facing a new era for massive rotator cuff tear. So without further delay, I'd like to introduce Dr. Guido Fierro from Colombia. Guido, please, over to you.
Thank you very much, Dr. Inho, for your kind introduction. I'm going to share my slides right now. Okay. Okay. Hello, everybody. I'm Guido Fierro from Bogota, Colombia. So thank you with all of you to be here with us, sharing this knowledge about this topic that everybody, I'm pretty sure everybody wants to know the current status of the balloon with our panel. I'm going to talk about the current situation and evidence about the subacromial spacer balloon and what will we found if we Google it or we search it in PubMed about this topic. This is my disclosure. When we're facing the subacromial spacer, you can have three of these thoughts. Maybe you can think, do not use it, doesn't work, maybe works, or works, use it, you know? And when you're thinking about this, the history of the balloon is a turning point history. At the beginning, looks like no, maybe one works, maybe with the history of the medicines, some papers show us that, hey, maybe works. And now the pendulum is going back and say, okay, maybe, I don't know if it works or do not work. And how can we decide if the balloon works or do not works? According to the evidence. When you are facing the evidence, you have this pyramid. And in the balloon, you have many of these papers, like case reports, technique papers, a series of cases, or retrospective paper. But we don't have many of, actually, we just have two of these good papers when we are facing the balloon evidence. And the key of this pyramid, the key of this situation is compare with. What happened if we compare the balloon with nothing, with just debridement and biceps tenotomy, partial repair, complete repair, superior capsular reconstruction, or reverse shoulder arthroplasty? What happened? I mean, what happened when you compare the balloon with these techniques? That is the key of the question. And actually, that is the question that I really want you keep after this talk. When you go to PubMed and search about the subacromial spacer, you can find many of these papers. But there is a group of papers that never compare. And when you do not compare the balloon, you find that the balloon works, yes, and is safe with just a report of complications, but in general is safe, and improve the result of our patient if you compare with the preoperative status. But I mean, the most famous of this case, of this type of paper, if this paper for Senecovic and Dr. Deckel, that show us that after 1 year, the patient keep improving their constant score. And we have other papers like this. I'm just bring this few example that what you will find in the literature. With 32 patients, is a tier of 2.3 centimeters, and you will find that the ASIS score and numeric rating scale improve if you compare those patients with the preoperative status. And look, the healing is 81%. But the question that you ask yourself is, hey, what happened if I do not use the balloon in the same patient? Maybe the result will be the same or will be different. That is the question that these papers do not resolve. And we have other case of series that show us that maybe it's not different, and those patients has early revisions. After those kind of paper, we have other papers that try to compare the balloon with other technique. And when you compare the balloon with other technique, you find that maybe it's no different, or maybe have a little clinical different in the group of the balloon. There are other type of paper that is a cost-effective paper, but it's hard to talk about the cost effectiveness when you really do not know if the balloon works. And this paper, I like this paper for this table. You know, this author, Dr. Laderman, Dr. Adwal, and the rest of the authors show us that if we do just a partial repair, the scales improve too, and look, improve almost the same that the balloon improve, or other techniques improve the results. Again, these results is for the studies in the bottom of the pyramid. Okay, but what happened if we have better studies? What happened if we compare? What happened if we do prospective studies? That is the reason, because Dr. Verma, Dr. Metcalf, and Dr. Drew are here, because they have these good papers in the top of the pyramid. And remember, when you are facing the bottom of the studies of that pyramid, maybe you keep with the dude about the balloon is really safe, is cost effective, really works. You cannot answer these questions with these old studies. Maybe you need better level of evidence if you want to change your decision. Remember, the literature is full of bias, full of conflict of interest, and take care about the industry and the pressure of the industry behind this balloon. Remember, you really need the best level of evidence if you want to give to your patient value in your treatment. Value is the results that they really matter and the cost that you pay for that. Thank you very much.
Thank you very much, Piero. It was great overview on balloon spacer. Now we are going to move on to the next speaker, Dr. Nikhil Verma. And Nikhil is going to talk about in-space implant compared with partial repair for the treatment of full thickness massive rotator cuff tear. His research work is amazing because it's a multi-center, single-blinded, randomized control trial, and hopefully we can share his experience with us. Over to you, Dr. Verma.
Great, thanks very much. And congratulations to the SICOT organizing team for the great work in putting together the platform, and also for hosting this webinar, inviting me to participate today. So as you heard, my task today is to discuss the U.S. clinical trial regarding the subacromial balloon spacer in the management of irreparable rotator cuff tears. I am a consultant for Stryker. I have no financial interest in the device itself, but I served as a consultant during the time frame of this clinical trial. So I think we're all aware of the complex treatment options that are available for management of patients with massive rotator cuff tears. Traditionally, they've included rotator cuff repair with or without augmentation, tendon transfers, and reverse arthroplasty. In the last 10 years, we've had increasing discussions about superior capsular reconstruction or graft interposition. And now in the last year in the US itself, the availability of the subacromial balloon spacer. I think we all need to keep in mind what are the indications for patients undergoing not only the spacer, but all types of soft tissue procedure. And generally, these are indicated for patients with primary or revision surgery without arthritis, maintenance of pre-op elevation, those who prioritize pain over function. And we should always keep in mind age, cost, and complications. And the SUGAIA classification has been very helpful in helping us to decide which patients are available for rotator cuff surgery, including balloon interposition. And generally, grades 1 and 2 are green lights, grade 3 is the yellow light, and finally, anybody with above a grade 3 should be contraindicated for these types of procedures. So why use the balloon? There are several advantages: simplified surgical technique, accelerated rehabilitation, which is a huge advantage for our patients, early clinical improvement, particularly with regard to pain relief and range of motion, and improved patient satisfaction. The surgery itself is very simple. I think it's important to manage all aspects of pain generators within the shoulder. So generally, we're performing an intra-articular debridement, some form of subacromial decompression, maintaining the CA ligament. AC joint and biceps are addressed as needed. And then finally, implantation of the balloon, which in our experience generally takes somewhere between 2 to 3 minutes, as seen in this brief video clip. So the question, of course, that all of us face when we look at this device, and many of us are skeptical when we first see it, is does it work? And so we're going to present to you the results of our US clinical trial. The purpose of this study was to evaluate the safety and efficacy of the InSpace for the utility in treating massive rotator cuff tears in comparison to partial repair. To complete a study of this size cannot be done alone. And so I want to acknowledge all of the co-authors who helped to participate and complete this work in a timely and effective fashion. The study design was fairly complex. It was prospective, multi-center within North America. Over 20 sites participated, randomized control, 2-arm between partial repair and the balloon. Subjects were blinded to treatment. The methods overviews, I think, are important. The subjects were randomized 1-to-1. We looked at the total operative and balloon time, the number of anchors used. Follow-up was at standardized timeframes. We collected standard patient-reported outcomes, with our primary outcome variable being the ASES score. And we did evaluate the subject changes over time, the change from baseline. And we put this in the context of what's meaningful for the patient. So we looked at the MCID, the minimally clinically important difference, SCB, or substantial clinical benefit, and finally the patient acceptable symptom state. This is a very important slide regarding our inclusion and exclusion criteria, and I think this helps to guide the usage of the balloon. These were older patients, full thickness, massive, irreparable rotator cuff tears, generally greater than 5 centimeters. They had significant pain. They had failed conservative care, which in most patients included physical therapy and injections. They had a functional deltoid and preserved passive range of motion. We excluded patients that had significant arthritis, that had a dysfunctional subscapularis, generally a subscapularis tear that would require repair or was irreparable, and they had some form of a deltoid deficiency, joint trauma, or those that had a completely repairable rotator cuff tear. We did standardize the rehabilitation. This was important to maintain blinding in the study. So all patients were immobilized for 4 weeks, then progressing with range of motion. Strengthening was initiated at 12 to 14 weeks after surgery, but we do feel that this can be accelerated in the balloon group going forward. You can see here that we had about 90 patients in each group. The mean age was 66, so as you would expect, an older population. They had long-term symptoms over almost 3 years. The groups are very similar at baseline with regard to their demographics, and we had very high patient retention with in-person follow-up, almost 90%. Here you can see the different procedures that were performed between the two groups, and there was no difference in the concomitant procedures between the two groups. So what are our results? At 2 years, we found very similar outcomes with regard to our primary variable ASES in regards to patient significant outcome measures. About 80% for both MCID and SCB in both groups. PASS was about 50% in both groups. So fairly favorable outcomes for a very challenging patient population. There were no difference between the groups at any of the time points. Range of motion was very interesting, and this watershed plot at the top right of your screen, I think, is very helpful. What we found is that in those that lost motion, and these were the minority of patients, there was less motion lost in the balloon group compared to the partial repair group. In those that gained motion, which was more prominent amongst the groups, there was more motion gain in the balloon group compared to the partial repair group. And we did find statistically significant improvement in range of motion in the balloon group compared to partial repair at both early and late timeframes. So the balloon was very friendly with regard to range of motion recovery. In terms of the other outcome variables, the Western Ontario Rotator Cuff Index, the constant score, quality of life measures, and VAS scores, really we found that the groups performed almost the same, although at certain time points there were improvements in the balloon that outperformed the partial repair group. In terms of operative time, this is where the balloon really shined, about 71 minutes in total for the partial repair groups, 44 minutes for the balloon group, and the average insertion time was about 4 minutes. So it shaves about 30 minutes off of the procedure itself. Complications, of course, we heard about this in the last talk. The safety profile was very favorable. We had no direct complications in either group and no direct complications related to the balloon, such as infections or device removals. In terms of reoperations, we had 3 in the partial repair group, 1 scope, 2 conversions to reverse. very similar in the balloon group. 1 scope, 2 conversions to reverse. 1 patient fell and had a fracture and required conversion to reverse. So again, these are very favorable outcomes for a very challenging patient population in both groups, with only 2 patients in each group going on to reverse shoulder arthroplasty. So in summary, we saw comparable to better outcomes between balloon over partial repair at 2 years. The benefits were early, particularly with regard to pain relief and range of motion recovery. And we found success without sacrificing range of motion, and really a very favorable safety profile with regard to the procedure itself, and significantly faster. So this is just one of my patients, a 67-year-old male, shoulder pain for several years. You can see he had failed a conservative course. His goal was really pain improvement. You can see he had a massive retracted rotator cuff tear. I would suggest that this is biologically irreparable. We treated him with the balloon, and this is his 2-year post-op visit with good functional recovery that was maintained over time. And we now have patients out to 4 years, and I've yet to convert one to a total shoulder arthroplasty or reverse arthroplasty here at Rush. So where does this fit in? I think this is for an older, low-demand patient who prioritizes pain over strength recovery. I think it's important that patients have maintained function in the preoperative setting. This is probably not a device that will resolve true pseudoparalysis, and we should avoid patients with minimal arthritis. And I think these indications are extremely critical in terms of choosing patients that may benefit from this procedure itself. There are some remaining questions in terms of how important is the role of the subscapularis, and if we repair it, can we still use the balloon? I do not believe that we can reverse true pseudoparalysis, but that's yet to be seen. The durability over time is certainly a question mark, but we're out to now 4 to 5 years in some of our study patients, and we find that they're still performing well. And what about using the balloon in combination with a repair? One study that was quoted earlier shows some early favorable benefits, but we need higher quality literature before we can recommend this. Thanks very much for your attention.
Thank you, Dr. Burma. I think we have numerous questions from the audience and the faculty members. Do you have any questions, Dr. Guido?
Yes, I mean, more than a question, I would like to summarize the talk for the audience, Dr. Burma. And your conclusion about the indication of the balloon is an older patient, low demand patient with good movement, with pain in the subacromial space. I mean, that is the concept until now about the indication of the subacromial space, no?
Correct. Yeah, and I think that's extremely critical. I think what will happen as we start to see mission creep with the wide availability of the device, I think if you start to stretch the indications, we may see that the results fall off. And frankly, that's true for SCR, that's been true for tendon transfer, that's been true for any soft tissue procedure in regards to rotator cuff surgery. So I think where this balloon fits in is for those older patients. They come into your office and raise the arm up. They say, I just want to be able to sleep at night. They've got minimal arthritis. And really a reverse arthroplasty or an SCR or some type of a greater procedure is going to expose them to higher surgical complexity, longer recoveries, and potentially higher risks of failure or complications. And if you stick to that sweet spot, we've been very satisfied with the use of the device to date.
Okay, thank you very much. I would like to see and hear the talk of Dr. Metcalf and Dr. Drew. And after that, I would like to share some situation that I'm pretty sure they will make the audience understand better the indication of the balloon. Thank you very much.
Okay, Dr. Fierro, would you like to introduce the next speakers, please?
Yes, I mean, Dr. Metcalf and Dr. Drew is from UK. I mean, they did one of the, I mean, I really like your paper. I really want to see you talk about your paper, because it's a paper that without any, I mean, with a good design, with a good number of patients, and this is a paper without any interest of conflict that I'm pretty sure will make us understand better the situation. Please, Dr. Metcalf and Dr. Yu.
Great, thank you for having us. Yeah, really good of you to invite us to this platform. It's fantastic. fantastic thing. So great to be able to discuss it, and great talk for the last talk as well. I found that really interesting. Thank you. So great. So I'm going to talk about our paper, which, as you know, is called, the logo is called Start Reacts. This is our sort of logos and things and our funders, but we'll explain to you who funded the study in the background. So the study was funded by a body called NIHR, which is basically the UK sort of government health funding body. Medical Research Council is another one of the government bodies. And we did receive some free devices from Orthospace and later Stryker, who also funded some of the training costs, but we had quite strict contracts with them that maintained our full independence. In terms of conflicts, key conflicts are, we're also running some studies on Mako, which is a Stryker product, but there's probably nothing else that's too critical in terms of conflicts of interest, but they're there. So irreparable rotator cuff tears, I'm not going to repeat what's already been said because you've had some really good summaries of that. They're common. There's lots of treatments out there, but actually the evidence base is pretty limited for most of them, and with few perfect options. It is a tricky condition to treat. And the InSpace device has been this sort of new and exciting approach. It was CE marked, which is the sort of European approval process. In 2010, it's been used about 30,000 times in Europe. I think, well, 29,000 times the last time I saw the figures. And that's, so it's become, if not established in practice, it's become more common in practice. And I think there's a lot of people across Europe who've become used to using this and started to see it, which is, of course, where the UK government got interested in funding it. Initially, a few case series, and we've already seen this data from this paper from Senekovic, which was the sort of classic case series on this with really good follow-up of 5 years, showing this gradual improvement, that's showing this improvement in outcome scores over time. And there's been now 19, in fact, I think 20 case series with about 350 patients in total, all of which with similar patterns, although quite different, a few difference of opinions between authors about how much benefit they're seeing. And I think there was a really nice introduction at the start by Guido about why we need comparative studies. And this was some of our data that supports the same opinion, which is we did a systematic review published in AJSM back in 2018, where we looked at all of the previous trials in rotator cuff tears. There was 57 of them at the time, and looked at the individual arms, including whether they've had non-operative treatment, operative treatment, any other treatment for rotator cuff surgery, and they all get better over time. So the point here is that the natural history of scores in people with rotator cuff tears is that they will improve. The question is, how much more will they improve compared to other options? So what we need here is randomized controlled trials, and the fact that we've got 2 good quality randomized controlled trials of a product here, a new orthopedic product, is a real advance for orthopedics. It shows where we're going evidence-wise, which is great. So NICE is the basically a government health body that looks at the cost effectiveness and effectiveness of health treatments used in the UK. Some of you may have heard of it, but they have basically assessed different treatments we're delivering. They looked at this subacromial spacer in 2016, recognizing that it was increasing in popularity. And through combination of expert submissions, manufacturer submissions, they defined what they felt was the current indication, which was irreparable rotator cuff tears who failed conservative management. They looked at the current evidence, which at the time was limited to case series evidence, and decided the procedure should only be used in the context of research. And that's what stimulated the trial and ultimately the funding that we received for it. I'm going to dive straight into the trial and into our inclusion criteria. And I very much agree with, I think Dr. Verma gave a great summary of what a good indication has been. And I think that was the feeling of our clinicians too. We had a slightly different approach by we said that the rotator cuff tear had to be deemed irreparable by the surgeon. And what that means is that when they were doing their diagnostic arthroscopy, they assessed the rotator cuff tear. And if they felt that it couldn't be repaired, then it was an irreparable tear. And that was confirmed intraoperatively. The majority of those were large or massive tears. Vast majority were large or massive tears. Of course, they need to have intrusive symptoms, particularly pain, loss of function, which warrants surgery. They need to have had unsuccessful non-operative management, of course. Exclusions-wise, again, agree on this. I think they had advanced glenohumeral osteoarthritis. So they had to have basic osteoarthritis on their pre-op imaging. Subscapularis deficiency. So if they had a very small upper border tear in the top 1 centimeter, and that's quite common in these cases, then that was okay. But anything bigger than a very small upper border tear was excluded. If there were younger patients, so those sort of patients, in the 40s and the like, who need interposition grafting or tendon transfers for better function, well, fair enough. But we very clear that we excluded pseudoparalysis, and I think the clinical opinion across the country was very much those aren't suitable, and so they were excluded. If they had something else going on the shoulder, they were excluded as well. And then other exclusions were what you'd expect for a standard randomized trial. If they had a muscular condition that meant they couldn't be assessed, or a previous proximal humerus fracture, then they were excluded. Ours was, it's a relatively straightforward trial in terms of design. Obviously, running these things is big and complicated, but it's a straightforward one-to-one randomized trial that's blinded. And they basically had the same operation with or without the balloons. They had an arthroscopic debridement, using the same technique as you do for a clearance for the balloon. And then they either stopped at that point, or they had the in-space device inserted. If the biceps was intact, tenotomy was performed. We did follow up at 3, 6, and 12 months with the primary outcome at 12 months. And we're just in the process of completing our 24-month follow-up. We had 24 participating sites across the UK. This is the sites listed. All of them were UK subspecialty trained consultant surgeons. They'd all been on shoulder fellowships, all shoulder specialists. They all perform the same arthroscopic debridement, very much as you've seen before. So a diagnostic arthroscopy. If the biceps was intact, the tenotomy was performed. They then did a debridement and bursectomy, but retaining the CA ligament. And I think that's seen to be important, both the balloon and some would argue for debridement for the irreparable cuff tear anyway. Our in-space technique, we were pretty careful with this. We had surgical videos, we had surgical manual, we followed the company guidance and checked that with the company carefully. There was actually a company representative present at over 85% of our cases to make sure we were doing this right. It was very important that we delivered that. We ran courses for surgeons if they wanted to come. We then took all of the arthroscopic photos, collected, reviewed them, and didn't see any errors in that either. So we were pretty careful about our technique. We had a consistent rehabilitation program. This was the same thing delivered to all. They all got the same physiotherapy booklet. The physiotherapists all got the same manual. We followed essentially the manufacturer's instructions, which was an early recovery, focused on early recovery, but allowing 2 weeks in a sling just for that very early recovery phase. And then it was effectively an anterior deltoid rehabilitation program, which we developed with a group of expert physiotherapists around the country, and again, checked with the manufacturer. You can read about our adaptive design. There's a number of papers that were written before we published them, before we analysed the results, as well as the paper itself. But given this is more of a clinical focus of meeting, I'm not focused on that. But that's essentially a way of determining the correct sample size for the study. This was our baseline data. So similar age group, 67, 66 between the two groups, similar male-female split. AP tear size, our mean was 4.3 or 4.2 between the two groups. That was well balanced. We collected pain-free range of motion. So that's the constant score method of collecting range of motion. So they basically go through the arc of motion and then stop when the pain starts. And that was well balanced between the groups. But as I say, don't be misled in the paper that this wasn't their full range of motion. They would be able to go beyond that, but this was their pain-free range of motion, which is pretty consistent with what you'd expect from other papers in the literature. And this is how we recruited, and we're really happy. Sites were actually really taking part in this, engaging with this, and recruiting well. And then, of course, COVID hit, and recruitment stopped. But interestingly, so did the adaptive design. And the adaptive design said, well, it's time to stop the study, your sample size is enough. And we'd planned to go up to a maximum of 221 people, but actually 117 people were randomized. And the clever statistical algorithm said that we'd got enough people. So we followed them up to 12 months, and we achieved 97% follow-up for those patients for our primary outcome. And in fact, for our scores in general. And this was our primary outcome results. And you all know this, so I won't surprise you with the results. We found a difference between the two groups, which was significant. And the debridement only performed better than the group with the debridement with the in-space device, with a mean difference of 4.2 points. And as I say, the only difference between these groups was the device. Now, it can be quite difficult to perceive what a difference of 4.2 points means. So I thought it might be helpful to show you the individual patient data in this study. So this is each individual patient who's taken part in the study. The blue group are the group with the balloon. The red group are the group with the debridement. And I mean, I think the size of the line is the amount of improvement they get if it goes up, and of course, getting worse if it goes down. And it just gives you a bit of a flavor and a feel for what the difference in the groups actually looks like in real life. And I think that makes it a bit easier to contextualize. We did some subgroup analysis, and often in trials, you do these subgroup analysis and rarely see a difference, but we found some really interesting results here. So tear size wasn't found to be a factor at all influencing results. Age didn't influence results. And we looked at acromiohumeral distance and didn't see, of which we had a broad range in the study, and didn't see that didn't have an influence on results. That's acromiohumeral distance at baseline. What did have quite a marked effect was whether they're males or females. And you've got to interpret this with some caution because the subgroup sizes get quite small. But the males, we've got very similar results between the two groups, but the females did substantially worse in the balloon group. Now, whether this is truly a male-female effect or whether this is a size effect, we don't know. And that'll, I think, will be something that's needed to be done for further research as well as further analysis. But I think that is important to understand. We took other outcomes as well, of course. I've included a couple of those here. So the WOMAC, the work scores, the WOMAC base score, the EQ5D, and change scores in terms of did the patients feel better, were they satisfied? And they were all in a very similar direction to the primary outcome, although most were non-significant. We didn't see any difference in safety events, and much as the other study, we only had one reverse shoulder replacement. And of course, that could have been in either group, but it was in the debridement with device group. We had 2 in persistent pain, 1 in each group. So essentially no difference in complications. We did a load of health economics, and it's probably not very surprising. The balloon was more expensive. The quality of life was very slightly lower, although not significant. And so the device was highly unlikely to be cost effective. It's a bit of a whistle-stop tour, that, but there's a lot of further details. You can look at, of course, the main paper. There's a supplementary appendix to that. If you want more details about our inclusion criteria, then the protocol paper gives a lot more detail. We've got lots of our study materials on our own trial website, and you're very welcome to contact us directly with questions, and our email address is attached there. So in conclusion, well, look, I think one thing to say here is that as an orthopedic community, we can be really proud of this because doing high quality trials is what we need to do for innovation. And there's 2 really high quality trials here now. So, this is exciting because orthopedics is really becoming a specialty of randomized trials. And our data, we didn't set out to find this, we didn't expect it, but we have to conclude we can't recommend the in-space balloon in its current status for people with irreparable rotator cuff tears with those results. And we think further research is probably needed defining if there's a group who benefit, and if there is a group who benefit, who are those people? And also when it shouldn't be used, and who will be made worse by it. And there's presumably a group here who are. And finally, of course, as you've heard already in these talks, there's a whole wealth of treatments for irreparable rotator cuff tears, none of whom have had this quality of evidence, or very little of it has had this quality of evidence. And there's a whole need for a lot more research in determining what is the best treatment strategy for these people. So great. Thank you very much. I will stop sharing.
Thank you very much, Dr. Metcalf. Now we have the 2 point of view for America and UK about the balloon. After Dr. Verma talk, it looks clear that the indication of the balloon, maybe in low demand, all the low demand patient with good movement and subacromial pain. But at that time, the balloon works, but a little bit more than the other procedure. But now with your talk, maybe the audience are thinking, hey, maybe the difference is nothing, and we should not use it. When you show us that the just debridement is even better in many of these situations than the balloon, may you think about this. I would like to keep this discussion with some slices. Let me share. Okay, about the indication of the balloon. You know, the really things in this moment in the world is when we should use the balloon. Okay, everybody knows the balloon. Everybody knows the way that we can put the balloon inside the shoulder. That is the easy part. The hard part is know if the balloon works and when works. Okay, and this is the context of this situation. Patient older than 50 years, 60 years maybe, without pseudoparalysis, good movement, no glenohumeral arthrosis, good subscapularis or repair subscapularis, and good Allier 3 or 4. We can divide the situation. You will see, and another 1 or 2, no more. Okay, I would like to know the Dr. Drew opinion about this situation, and then Dr. Verma and Dr. Metcalf. What happens if you're facing a patient with irreparable tears with no cuff repair? You go inside the shoulder, you do a bursectomy, biceps stenotomy, synovectomy, and you see that it's not cuff to repair, okay? But with a good subscapularis, okay? No supra and no infra. Dr. Drew, would you put the balloon in this patient? Yes or no, and why?
No, I would have done before our trial. So I was if you like, an early believer. I've been doing this for sort of 8-9 years now. And so, you know, the concept of the trial, if you look at my perspective coming into that trial, that would have been as someone who believed the balloon works. And so the result was a surprise to us in terms of its outcome. And if you ask me if I would use it now in that scenario, based on, I think it all boils down to what you compare it with. You know, if you look at our baseline data, both groups improved. You know, the Oxford Shoulder Score in the balloon group improved, the Oxford Shoulder Score in the debridement group improved. It's just in the debridement group, they improved more. And you've always got to look at what you're comparing it with. You know, what we never set out to determine, and that's almost impossible, is what's the best treatment for an irreparable cuff. You know, we'll do different things, but in the concept of the trial we did, as things stand at the moment with our result, I couldn't recommend putting a balloon in that scenario on its own.
Okay, thank you very much. Actually, that is the patient of your study. I mean, fit pretty well. And I would like to know the opinion of Dr. Verma of this patient, exactly this patient.
Yeah, so I think that's the hard part, right? Is we need a little more information before we say exactly this patient. So I don't know if this picture is meant to be representative, but there does appear to be some glenohumeral condylomalacia that's present, at least on the humeral head view. That certainly would be a concerning factor for me. I don't know if that's relevant or not. But again, I think the age, the demands of the patient, the expectations of the patient, and most importantly, the functionality of the patient is what would lead me to make that decision. If you told me their joint was healthy and they were an older patient, our subgroup analysis did seem to favor patients over the age of 65, and their function was maintained, then our data would certainly suggest that's the patient that would benefit from the balloon. And it's not to say that that you can't achieve successful results with either partial repair or debridement. But what we found was that you can probably accelerate the recovery with the balloon, which is relevant for this patient population. You don't have to sling them for as long. They don't have the stiffness issues that you see with partial repair and the difficulty with recovering range of motion. So I think you can get to the same place with multiple procedures, but one of the advantages that we found in the balloon is that you maybe get there quicker for these more, quote, limited demand patients. And I think we sometimes forget about the patient population and the burden of the surgery and the recovery. And if you can shave that recovery in half, that's a very relevant outcome measure, at least from a patient perspective.
Yeah, thank you very much. Actually, that is the question that I had when you heard your talks is because do you, I mean, you all do the same rehabilitation protocol for those patients, but what happens if we change the rehabilitation protocol? If you do a partial repair or and keep the time for healing for the cough, yeah, and what happens if you just put the balloon and start a active range of motion rehabilitation? You know, probably that is the thing that we should consider when we understand the data of these papers. I mean, the Dr. Verma, this picture is not for the patient. This picture is just for context, but it's just the situation, you know, and that's it. Okay, I have other situation. I mean, what happened if you are with this patient? Remember, this patient, I mean, it's a general situation, and you can perform an infraspinatus tear repair, I mean, without tension, but it's no supraspinatus. I mean, you cannot repair the supraspinatus. Dr. Metcalf and Dr. Verma and Dr. Drew, would you use the balloon in this situation when you have a good subscapularis and infraspinatus repair? Okay, now you have two tendons attached to the bone, but without supraspinatus. Would you use, or you would not use the balloon?
So I'll start. I think it really depends on the age of the patient and what their exam looks like. In
60,
a younger patient,
60 year, good movement.
So what about their external rotation? I mean, if they had an external rotation lag or a deficiency in external rotation, then I think repairing the infraspinatus is going to be critical. I do think that in a younger patient, this is hypothetical, that there may be a more durable outcome by repairing the infraspinatus. So I think that if the infraspinatus was good quality tissue in a 60-year-old patient, and you could repair it with some confidence that it would heal, I would probably repair it. If you take that same patient at 70 years old with good function, no external rotation lag, I would probably favor a balloon.
Okay, thank you very much. And Dr. Drew, would you use it?
So similar for the first one. So if it's a younger patient and you've got good quality tendon and I can repair the infraspinatus, yeah, absolutely, I'd repair the infraspinatus and just accept the supraspinatus deficiency. They'll probably then be balanced, and hopefully with some deltoid rehab, they've got a sort of balanced and compensated cuff tear, and they'll do okay. Older patient, you know, much more difficult. Again, based on our study, I wouldn't be putting a balloon in that patient. You know, I would be doing a sort of biceps stenotomy and an extensive debridement in that patient now, and see how they got on. Yeah, we you know, it's a fairly expensive implant, and we just haven't shown any benefit for it. So, you know, can't really justify putting one in.
Yeah, that is a really good point, Dr. Drew, because if you think that the balloon improved the results, but how much improved the results and how much are you paying for those number in the score? Please, Dr. Inho, give us your talk about this situation.
Thank you very much, Guido. I think Dr. Berman and Nikhil Verma, your study and Andy's study are two major cornerstone in shoulder surgery. I mean, I have no doubt. It's a very logical and reasonable study, and I think it's going to be an important reference for our future study. So to avoid any confusion for our participants and audience today, Dr. Nikhil, would you please comment why the study from Andy's had that contradictory result different from yours? And Andy, would you please leave any comment on Nikhil's study, why your result has been different from his results? Dr. Verma first, please.
I appreciate it. You know, as with any orthopedic condition, there's always conflicting results in the literature in terms of how things work. We've seen that with tendon transfer. We've seen that with other procedures in the past. And I think what it often boils down to is patient selection, or exactly which patients were being treated. And secondly, is there was a little bit of a difference in terms of the comparison procedure, as was mentioned, between partial repair and the balloon, which may have led to a difference in terms of one more favorable than the other, because a debridement is a simpler procedure versus the partial repair, and that may explain some of the range of motion data that we saw. And then finally, I think it's just in terms of the rehab perspective, they were much more accelerated than we were. We're currently designing a clinical trial that's just getting underway to look exactly at the question that's been mentioned in terms of how fast can you go with the balloon. Originally, I thought that you could go as fast as you wanted and there wouldn't be a penalty for mobilizing these patients quickly. In my own experience, as I've started to accelerate, I have seen the results somewhat drop off. And so I do think that that period of immobilization may be helpful to allow for recentering of the head, probably some scar tissue to allow the balloon to maintain stability, and therefore to function over that 3 to 6 month period before it begins to lose volume. You know, the one thing that I had trouble understanding about their study, and it was somewhat commented on, was the range of motion data. Our average range of motion was 90. I know that it was listed in the talk today as pain-free range of motion is 60, but I think the critical thing here is exactly what is the range of motion, because 20 degrees is a very strict definition of pseudoparalysis. I think in my experience, this device works best when patients have preserved range of motion, even if they're painful, if they can lift the arm completely. So, you know, I commend the UK authors on the study. I think that they're a little bit different in terms of how we did it and what we compared to that may explain the results. But I would agree with their final conclusions, which is we need to continue to study this concept to determine who is the exact indication for this. And then the last comment I would make is that I personally felt that their conclusion was somewhat strong in that there was a safety concern over the use of the device. We certainly have not seen any safety concerns that were specifically device related. I didn't see in their paper that there were true safety concerns in terms of people that were being quote unquote harmed by the device. They just saw a very small difference in the patient reported outcomes. So I think that that's an important discussion point as well, that in that both of the studies really did not show a significant quote unquote safety factor with regard to the use of the device.
Thank you. Andy or Steve, any comment?
Yeah, so look, I think there's two good quality randomized controlled trials. I'll agree with a lot of the comments that you've just heard. I think they are slightly different patient populations in terms of the selection criteria, particularly on size of tear. They are, you know, ultimately probably the big difference is the different comparator with the partial rotator cuff tear versus the debridement. And I think that has pros and cons. I think there's one of the benefits of ours is that you get that direct comparison, but equally I know that partial rotator cuff tear is a common practice for a lot of people, and so some people find that a bit more relevant to their own practice. So you know, that is definitely a difference between the two. Rehab protocols, yeah, I'll agree. We had a lot of discussion about our rehab protocols there, and we went with a 2 weeks in sling and then accelerating afterwards, which is what the guidance for the balloon was. But clearly, that's different if you're going to do a partial cuff repair, because you're going to want to protect those patients a little bit more. And I think we do need more research on the balloon. We just sort of, for me, you know, if we're going to use a device and there's this uncertainty, we need to understand, well, when should we use it and when's it going to work? And so this thing of, you know, let's try and find out what the right rehab program is. You know, perhaps there's a sizing issue, particularly with that male-female difference. It makes you wonder if there's a sizing issue. So maybe that needs to be resolved. And then if we can get all these things resolved and worked out, can we then do a study and actually show, you know, that there is a benefit, that putting that money, investing in that financial investment in, is actually going to result in a patient-focused benefit. To answer a couple of the questions about our study, so you know, we measured pain-free range of movement. People carried on until the point it started to hurt. We didn't, both for the sort of partly the ethical reasons and partly just the way that we ran the study, we used the constant protocol, because the constant protocol is so well described and understood in shoulder surgery circles that we thought to use a different protocol. And what point do you push people harder, and how do you control when you start to get scapular movement? And different sites will do that differently. We thought that was a very hard thing to control, whereas the constant score protocol is consistent, reliable, and well reported. So it just makes sense to use that. I don't think our data is at all inconsistent with the data that's out there, broadly on the constant score domains in these sorts of patients. So I think it's, I think our data is consistent with the population you'd expect that to be. And of course, they're pain-free range of motion, so these patients are going to move more. We asked surgeons to exclude patients with pseudoparesis. We gave a suggested definition, but actually we just said to them, pseudoparesis isn't suitable. And I think that's, so I don't think there's a pseudoparesis population here. The probably key thing is, what are we going to take away from this? So my takeaway from this is if we're going to use it, we need to understand it more. Now, ultimately, we found a significant difference. We didn't set out to. We thought we were probably going to see a difference in favor of the balloon. Someone showed us the chart at the end, and it took me a while to read the figure and realize it was the other way around to what I expected. But ultimately, we have seen a clinical difference between the two. We saw a lot more patients get worse in one group compared to the other. That's a risk to be spending money on right now for me. I think it is an interesting technology. I think there's more work that can be done. I agree that, if we can work out that indication and we can work out the population, we can work out the right rehabilitation regime, then maybe there's something in it. So there we go. I don't know. So Steve's our senior shoulder surgeon on the trial. So Steve, I don't know if you've got any to add to that.
Just one point. If you look at our results, it's quite clear that if you were analysing them, the overall Oxford Shoulder score is dragged down by the poorer outcomes in the female group, and that's a smaller number of patients where actually their scores are really quite poor. And that's sort of dragged the whole group down. And I think it's trying to understand that as to why in that particular group. So it's not uniform throughout females. It's a small number where their scores are significantly worse than the others. Now, is that a sizing issue? I mean, the in-space balloon comes in a fairly limited number of sizes, and virtually you never use the small size. So you're looking at, for the vast majority of patients, you're only ever putting in one of two sizes. And the other thing to say about it, it is convex. Is that the right shape to be putting in against a convex surface of the humeral head? So that's just two thoughts from my point of view. It's not something I would dismiss, but I think we need to understand it more. And is there something we can do to improve on it?
Steve, thank you very much. I totally understand this is not a something right or wrong issue. I mean, all medicine, we all evolved by doing this conflicting research works. So we have a very burning question from the audience. Can I ask Dr. Burma first? What if you use a balloon over supraspinatus repair? I think he is asking a kind of augmentation or protective purpose. What is your thought on that?
My thought is that it's a novel concept. My second thought is that adds extreme cost to a rotator cuff repair surgery. And finally, I would say that at least in the United States, that would be considered off-label use. And I just don't have any experience outside of the singular study that you quoted to be able to support that application at this time. So I think it's an interesting concept to discuss whether this may provide some type of a quote unquote internal brace that may help protect the repair over the 6 months. We need to contrast that with any inflammatory reaction that may occur as the balloon's starting to resorb. So I would say that needs study before it could be recommended. I just don't have any experience to suggest that that's going to be a favorable, provide a favorable outcome with regard to rotator cuff repair alone at this time.
So Dr. Burma is another question. You don't necessarily stick to your research work because your research work is absolutely amazing, but what is your personal gut feeling or insight on this balloon procedure? Do you think it's going to survive more than 4 or 5 years? What is your gut feeling? How long is going to last?
So my gut feeling is as follows. Number one is we know that for the vast majority of these patients, their rotator cuff pathology is not new, which means they existed in an asymptomatic state for long periods of time before something led to a decompensation event. Number two is we know that in patients that fail a rotator cuff repair, they can have good clinical outcomes. And at least in our data from when I was a fellow, suggests that those results can be maintained greater than 7 to 10 years. So I think that if we reset the clock and can reset these patients into a compensated world, I don't really see that there's going to be a significant risk of progression, but we know that this is a chronic disease and we certainly haven't cured it. So I think that there will be a small, limited group of patients that progress to primarily an arthritic condition that may require further treatment. But I think that there will be a substantial number of patients that will continue to exist in a compensated world and potentially not need further treatment for a substantial duration.
Thank you. So, Dr. Guido, would you like to summarize today's discussion?
Oh, I really like this discussion because, I mean, at least for me, I'm pretty sure for the audience now we have more clear the indication of the balloon, if we need to use it, if we don't need to use it, and at the same time, I think is keep the question about the future of the balloon. I mean, I was thinking in perform the same ask a question that you did, Dr. Inho, about the future of the balloon. I'm not sure. Personally, I'm not sure if the balloon in 5 or 10 years will be useful, but until now, and thanks for your papers, now we have more good information and good papers that we make us take better decision facing every patient. Thank you very much for your time.
Okay, thank you very much. You two guys gave us very clear view and very good comprehensive explanation, and I think it was very helpful for our SICOT members and all the participants today. And at the last, our SICOT headquarters would like to share an important message to you all. So please fill out our post-webinar survey so that you can have a personalized certificate of attendance. If you click this picture, you can have this certificate. And our SICOT annual meeting is going to be held in Kuala Lumpur this September, and it's going to be a very interesting, exciting face-to-face meeting. Thank you very much. Once again, guys, thank you very much for your time, and I hope your experience and the lecture will be helpful for all the participants today. Thank you very much.
Thank you all. Thank you.
Thank you.
Thank you very much.
And you did a great job today. Thank you very much.
Yeah, thank you. No, thanks for inviting us. It's great.
Thank you very much.
Good
Thanks,
discussion.
guys.
Dr. Verma, nice to meet you as well. Thank you.
You too.
Yeah.
Take care, guys. Thanks.
Excellent.